I'm going to stay down here. Our next speaker is Dr. Liz Sokol. She's an assistant professor in the Department of Pediatrics, the section of Pediatric Hematology Oncology and Neuro-Oncology and Stem Cell Transplant at Lurie Children's Hospital here in Chicago. She has received her BA in biochemistry at the University of Pennsylvania and her MD at the University of Illinois at Chicago. She did her residency, fellowship, and postdoctoral fellowship at University of Chicago Comer Children's. She is a member of numerous societies and has co-authored, again, numerous publications and book chapters, and her talk today is on genetic alterations in neuroblastoma. Dr. Liz Sokol.
All right, thank you. So we're going to take a little bit of a step back here with this talk to kind of zoom in a little bit on what people have been talking about in some of the prior talks and give a little bit more background about what we're thinking about when we talk about genetic alterations. What are those? How do we think about those? How do we frame those things? And what are they? Okay, so I have no disclosures for this talk. So genetics is a very broad field that has evolved greatly over time. And really frames a lot of the work that we do in the way that we're treating these patients with neuroblastoma. So zooming in here from the level of the tumor cells that we have inside of all these cells, we have things called chromosomes, kind of those X-shaped structures that are made up of our DNA. That the DNA is comprised of pieces that we call genes. That are all made up of base pairs at the most basic level there, the letters that define the sequence of these things, that define how all of our bodies work and function. At the most basic level, alterations in this can cause all kinds of changes from what color our hair is to how a tumor behaves. When we think about genetics in cancer, we have to make a distinction between changes in the DNA in our whole body, and what we term germline changes, to what happens in just the tumor itself. And there can be alterations and are alterations that are not present in all the cells in our body, but are really present in the tumor. And in the spectrum from normal cells here to the tumor cells, there can be alterations that occur, errors in DNA as they replicate that lead to the development of a tumor. So all cancers have some kind of genetic alterations that cause them to grow out of control. And those are often, certainly not always, related to changes in the whole body. So when we think about these genetic alterations, what are they? What do they mean? Well, we'll use sort of an analogy here, thinking of the DNA as a sentence, where we have a series of words. So in this case, the gray cat ran down the hall. And there can be small changes in that sentence that change what the sentence means. And in the sense of a tumor, it can change the way that a tumor behaves. There can be single base pair changes. Those missense changes, that first example there, where the H becomes a B, single change changes what it means. The gray cat ran down the ball. Maybe that doesn't make any sense. Maybe that's going to lead to a tumor that doesn't that grows out of control because that word no longer makes sense in the typical way. There can be base pairs added, genes added, that here a gray-green cat. So again, changing the meaning of the sentence. The words can be deleted in the same way, they can be duplicated, or there can just be truncations or things where we just lose genetic material. These are what we call nonsense mutations. So all of these things, in the way that they change the meaning of the sentence here, change the way that a tumor might behave. So those are all different types of mutations. The other thing that I don't have sort of in sentence form here, but we talk about translocations at time, which means you basically take two sentences that you have and they fuse somewhere in the middle, taking part of one, linking with part of another, and again, changing the structure and the meaning of what those things are. So first thinking about the changes in tumors in neuroblastoma, so not talking about the germline whole body changes, but in the tumor, two of the genes that we hear most often about are MYC, N, and ALK. We've already heard them in multiple talks already today. But these are well-characterized, well-known changes that alter the way that tumors behave. MYC-N is a gene that was identified early on that we know some proportion of neuroblastoma tumors have what we call amplification, which is not only one extra copy of this gene, but many extra copies of this gene. When we see that MYC-N amplification, that can be associated with poorer prognosis. And about 20% of neuroblastoma cases have this genetic change. As Dr. Desai mentioned, this is something that we use in the base risk stratification because we know that this can predict high-risk behavior in the tumors. ALK can be altered in a number of different ways. There can be amplifications as well, mutations or fusions, all that can happen in this gene in particular. It's altered in a proportion of neuroblastoma cases. I have 6 to 12 here, depending on which publications you look at, that number is a little bit varied. And we know that these patients with ALK aberrations can have higher rates of disease relapse or recurrence, which is why we're really looking at targeting that in our upfront studies, as has been already mentioned as well, especially in our high-risk patients, looking at the addition of ALK inhibitors early on to try to mitigate this increased risk of relapse that we see with these patients. Another set of genetic alterations that we see in our patients, this was alluded to a bit by Dr. Desai talking about our adolescent and young adult patients with neuroblastoma, although not the classic patient, the toddlers that we see, are alterations in telomere maintenance. So telomeres, as pointed out in this image here, are the very ends of our chromosomes. And there are mechanisms that cells have to maintain these telomeres, which can maintain the integrity of the DNA. And as people age, we naturally see shortening of these telomeres. So it's a normal process that happens. Now, some tumor cells have mechanisms to maintain those telomeres, to allow them to replicate over and over again, allowing the cells to grow and not to age, as would normally happen with cells. And so various tumors have alterations in this, including neuroblastoma, that allows those cells to replicate faster and more than would healthy normal cells. And so these genes, TRT and ATRX, are genes that alter the function of telomeres. We often see these in our older patients, as we alluded to, that can have these changes and allow the cells to survive longer than they would. And they can be additionally associated with therapy resistance, not responding to our therapies in the same way that we might otherwise. And so these are some genetic changes that can happen that dictate the behavior of our neuroblastoma tumors. Other genetic changes are identified, although globally, when we think about neuroblastoma in general, there are fewer mutations than we see oftentimes in adult malignancies. Important to point that out. So when you're talking about breast cancer or colon cancer or other types of common adult malignancies, there are many, many mutations that build up over time, over the course of those adults' lifetime, and make a complex genome in those patients. We see many fewer alterations and many fewer mutations in neuroblastoma and other pediatric cancers as well. That said, there are some pathways that can be altered. This RAS-MAP kinase pathway, as I have alluded to here, and the gene P53, these are common genes that are affected in a variety of cancer types. They're not specific to neuroblastoma, but they can be altered in a variety of ways to make tumors more aggressive or lead a cell to become cancerous. Some of these genetic alterations have specific drugs that can target those pathways, so we have those potential down the road to utilize, but these are much less common in our neuroblastoma patients compared to other tumor types. These can also potentially be identified more often in the setting of recurrent neuroblastoma, so we don't as often identify these up front if we're looking at the sequence of the DNA in tumors at diagnosis, but may find them later on with tumors that have relapsed. So switching gears a little bit to something that is more common in neuroblastoma tumors, and this is what we call copy number changes, changes in the amount of DNA that we have. So I have two different figures here from work that was published back in 2011 by Dr. Schleiermacher that looks at different ways that the chromosome numbers can be altered. So to orient you to these figures a bit, across the bottom here, we have all the chromosomes that exist in our cells, from chromosome 1 to chromosome 22, and then the X and Y chromosomes. And so what this figure is showing us is a deviation from that midline shows either extra DNA or less DNA than there typically would be. And so in the top figure, if we, for example, look at chromosome 2, see if we'll see this here. You can see that there is that red bar that rises up over that midline to say there's extra copies of chromosome 2 there. There's more than there would typically be, but it's level across that line, across the whole chromosome 2 time frame there. So in this particular patient, they have extra copies of the whole of chromosome 2. So that would be a whole chromosome gain, we might call that. On the flip side, on the bottom line there, you see there's some extra DNA from chromosome 2 present in this bottom one, but it's just the beginning part of it. It's just that early part of chromosome 2. That would be what we call a segmental chromosomal change. So there's extra DNA there in that case as well, but only part of it. So the DNA is a little bit more broken up, is a little more irregular. And so these are the two main sort of patterns of copy number changes that we can see, either whole chromosome gains and losses or segmental chromosome gains and losses. And these are associated with different prognostic significance. So as mentioned there, more common. So when we see the segmental changes, when there are those pieces of gains and losses, this is often associated with more aggressive disease and inferior survival, as opposed to the whole chromosome gains and losses are often associated with better prognosis. Right now, this is used through the Children's Oncology Group in intermediate risk disease to stratify, making sure, and the study ANBL 0531, as Dr. Desai had alluded to, had utilized this sort of data to say, do they have a favorable biologic profile or a less favorable profile? And would stratify the amount of cycles of chemotherapy those patients received based on that information. In multiple different types of analysis, certain chromosomal changes have come out. So this here, thinking about these segmental changes, where we have the, again, partial gains and losses. Here we have listed what has been termed the thiopin 7, or some common patterns that are seen over and over again, where we may have gains in chromosome 1q, 2p, or 17q, or losses in 1p, 3p, 4p, and 11q. And just to clarify, what does that mean? I show you a copy of a picture of a chromosome here again. The p and q refers to which arm, which part of that chromosome is changed, the p being the shorter part of it, and q being the longer part. And so again, we may have changes that lead to there being partial chromosome extra or less than there might otherwise be. And when we find these things, it tends to be, again, more aggressive disease. As opposed to here, I show an example of whole chromosome gains. This is often a phenomenon that's seen in infants with neuroblastoma, our youngest patient. But you can see here, for example, chromosome 2 that we've talked about a couple times. In this particular example, there are 4 copies of chromosome 2, whereas in a normal cell there would be 2. And you can see in other chromosomes here, there are also extra copies. So switching gears a little bit, those are all changes in the tumor itself. But there can be, in certain cases, changes in the whole body, in the germline of the patients as well, that may make them more prone to developing neuroblastoma tumors. This is significantly less common. In most of our patients at this time, we do not identify a predisposition that identifies why they develop their tumor. Although these associations certainly exist, this is relatively more infrequent. So I start here with this saying, germline genetic testing is not always recommended, and in most cases it may not be, but your physician likely asked questions about family history. Are there other cancers that have triggered a concern for a germline alteration, or other clinical features, other symptoms, or other features of the patient that may indicate there may be an underlying predisposition. So we'll go through a couple of the predisposition syndromes that can exist. First, here we mention a group called neurocrestopathies. So this is a series of types of syndromes and patients who may have a number of types of medical concerns even beyond their tumors. The first group have alterations in a gene called FOX2B. They may have a syndrome called congenital central hypoventilation syndrome. These patients have a variety of findings and medical needs. Altered breathing. They may not breathe as readily as they should. The nerves don't trigger their breathing in normal ways. They may have altered nerves within the GI tract, causing something called Hirschsprung's disease. These patients can have altered nerves that feed the heart and have cardiac arrhythmias. And so this is a syndrome that really impacts nerve development, and these patients can have an increased risk for neural crest tumors, including neuroblastoma and ganglioneuroblastomas, et cetera. A semi-related syndrome is called Rowe-Head syndrome. This one has a much less understood genetic backbone, but can have similar features where there is rapid onset obesity with, again, altered breathing, some endocrine anomalies, and these patients as well can have increased rates of these neural crest tumors. It is fairly unusual in these syndromes to find the neuroblastoma first, whereas many of them will have presented with the breathing changes, the intestinal changes, and then later identify a tumor. So often we're not sort of back testing looking for these things because the clinical presentation of the patient will guide us if these things are a concern. Other predisposition syndromes. So ALK, we talk about it most of the time in the setting of a somatic change, but there are a few families that have been identified that have familial neuroblastoma that is presented in multiple generations of patients and have a germline ALK gene change. And so while this can be altered in as many as maybe 15% of neuroblastoma tumors, it is a much, much, much more rare phenomenon to have ALK altered in the germline of the patients. But this would be, testing for this would be driven usually by family history. So for these patients that have these predispositions, whether they have other medical concerns or they have an ALK germline mutation, what do we do? How do we monitor those patients? So those patients would have surveillance done for neuroblastoma. It's different than the surveillance that Dr. Desai mentioned in sort of the general population, where we really found low-risk tumors and did not impact outcomes with our surveillance. In patients who have a known predisposition, we do recommend surveillance with ultrasounds of the abdomen, with x-rays of the chest, and with those urine catecholamines. More often when they're younger, so before age 6, every 3 months, these patients may have surveillance, and in years 6 to 10 with every 6-month surveillance. And because neuroblastoma, as it is in all patients, becomes less common after age 10, we typically do not do surveillance after that time, although we know that it is possible to develop a neuroblastoma after age 10, certainly. Okay, so there are a couple of other syndromes that are not very neuroblastoma specific, but that can increase the likelihood of developing a neuroblastoma as part of it as well. These are patients, again, who may have other findings, may have developmental delays or intellectual disabilities, may have other birth defects and genital anomalies, may have altered growth, may have skin abnormalities, may have hormonal changes. This is a fairly broad list of potential involved signs and symptoms because these are a variety, a range of diagnoses that can come with a potential increase for neuroblastoma or potentially other types of malignancies as well. Again, these are often identified because of the other findings, the congenital anomalies that present, the other things that may be associated with it. And so the screening that might be recommended really depends on what the syndrome is and how likely that increased risk of a malignancy is. I I think these are similar to the slide that Dr. Desai showed you, some of these examples of these syndromes that could be altered and come with an increased risk of neuroblastoma. But Costello syndrome, Noonan syndrome, Fanconi anemia, Beckwith-Wiedemann, and Weaver syndromes as some examples. And then there are some other family cancer syndromes that can come with increased rates of neuroblastomas as well. These may not have other congenital findings, other findings that may point out to these other than sometimes the family history, although anything can develop at any time. So Li-Fraumeni syndrome is sort of the classic prototype of a cancer predisposition syndrome, where there's a germline alteration in this gene P53 that can predispose to the development of lots of different types of malignancies. Neuroblastoma is not one of the classic Li-Fraumeni, which is the name of the syndrome here, diagnoses, but it has been reported in families with Li-Fraumeni syndrome. And here, this next one, this familial paraganglioma or pheochromocytoma syndrome, is neuroblastoma, again, is not the classic diagnosis associated, but has been reported in these, and these patients are at risk for other adrenal tumors as well. So screening in these patients is not really targeted at neuroblastoma screening, so often does not include things like urinary catecholamines, but the screening that would be done for a variety of cancer types in these patients may pick up things like neuroblastoma when that's done. So circling back a little bit, so when do we do this germline testing? When is this recommended? By and large, most patients with neuroblastoma, they don't need to have germline testing done. Now, in some families, if there's a significant family history of cancer, that may trigger some testing and referral to a cancer predisposition program that has genetic counselors and teams of physicians who specialize in this to look for underlying genetic predisposition. Sometimes the clinical symptoms, the other medical concerns that a patient has may trigger some testing. Or sometimes if someone has done analysis looking at the tumor itself, there may be a finding that may be identified that they say, well, maybe that could be a germline finding and may reflex after doing testing on a tumor that says, let's look in the germline as well. And so most of the time, again, this is not done, but it's something that's often in the back of the minds of pediatric oncologists thinking about patients who are developing cancer and tumors early on in life, and how we can make sure that we're thinking broadly about how to look for other findings that may be related to their neuroblastomas. Typically, these things, the genetic testing, the germline changes that we identify, do not typically impact the treatment that is done. We still need to do everything that is needed to treat and cure the primary cancer. And so, although these information is helpful for us to think about the future and planning for potentially the patient and family, it's not going to change typically the treatment that would be given. So that's all I have. I'd be happy to take any questions at this point.
Thank you, Dr. Sokol. Does anyone have any questions? Nope. Okay. Oh.
Thank you so much for your presentation. My name is Marna Costanza. I'm from South Carolina. Actually, I have two questions for you. The one has to do with the development of drug resistance during neuroblastoma treatment, and the other one has to do with cell-free DNA.
Okay.
So in terms of, well, we all know that frontline treatment for neuroblastoma contains combined drug therapies because that seems to be more effective. In some other systems which are granted, less complex, so, the evolution of drug resistance in bacteria or something like malaria that's, a eukaryotic parasite, they found that the pathway from being completely susceptible to a type of drug treatment to becoming resistant is predictable. So even though conceptually there are, maybe millions of pathways to becoming drug resistant, genetically they only follow a few, right? And so I was wondering if in neuroblastoma that's something that is possible to study, or if it's been observed that you can either predict what type of drug resistance will evolve from treatment, or you can tailor specifically which drugs used together to stop that?
Sure. It's an excellent question. And I think you kind of alluded to the answer to some degree that I would give you, is that neuroblastoma and many tumor systems are just so complex and heterogeneous. And so I think it becomes difficult to predict because you may have part of a tumor that becomes resistant in one way and another part of the tumor that becomes resistant in another way. And so trying to see from the time of diagnosis what may happen, I think is very challenging. We do use multimodal therapy because then if there's resistance to one agent, you may overcome that with other drugs. And in neuroblastoma, certainly in high-risk therapy, we do that in sort of the nth degree with lots of different types of modalities of treatment, from different drug types to radiation to immunotherapies. But I think it's very challenging to know from the outset which part of a tumor may sort of become the part that's going to be problematic, and how to target each part of that tumor specifically. So I don't think we have those answers with current technologies, but certainly in terms of analyses looking at single cells and doing single cell analysis, I think people are working to try to understand that more so, but I don't know that we have the ability currently to really identify those resistance mechanisms up front.
So one more question.
Sure.
Just with most people here who've had kids who've had neuroblastoma, you get the tumor gets sequenced, you get the chromosomal level data. But now that being able to test cell-free or circulating DNA is more accessible, are there any, is there any development in that? Are there situations where that's helpful?
So there's certainly a lot of work as partially being done by Dr. Applebaum here, looking at the use of cell-free DNA. So if you want to, yes, go for it.
Yeah, so in terms of cell-free DNA, that's an excellent question. My lab studies a lot of it. So there's a lot of different platforms that are out there to look at cell-free DNA. I know, there's groups looking specifically at very targeted panels for 23 genes, that most likely to be involved in things like ALCA aberrations and RAS-MAP kinase mutations. There's groups that are looking at whole genome sequencing and what can we learn from copy number, and also doing deep dives on that. And there's also trying to look at actually the question of tumor evolution. How do things change over time, as tumors get exposed to different mechanisms? Our lab is looking at epigenetic markers and sort of how things are being utilized. And there's a lot of work being done on samples collected off of AMBL 1531 that's going through this. There's a lot of in-house studies, so there's a lot of work being done on it. The Children's Oncology Group actually also just started a cell-free DNA working group to start thinking about how do we actually incorporate cell-free DNA into clinical trials, and how do we use those as informative biomarkers. That group has met once, so it's very, very early days, but it's something that I think a lot of us are thinking about. Yeah, no, and Dr. Desai is pointing out, right, cell-free DNA isn't a perfect marker of tumor. I think some of us would argue that it's a marker of some of the more aggressive parts, that, if you see a mutation in the cell-free DNA, you're actually more likely, and I think Dr. Mose showed this, you're more likely to catch important mutations that may identify therapy in the cell-free DNA than potentially in the tumor. And I think Dr. Sokol was mentioning, right, tumor heterogeneity. Depending on where you stick that needle, you might get a different answer. Whereas cell-free DNA, we hope, might be a sort of a conglomeration of all the different cells that we can target. So, to be determined.
It's coming.
We have a question over there.
Hi, I'm Bendy Shetler. I'm from Atlanta, Georgia. This is kind of a little more specific of a question in regards to the mutations that you were talking about. You're talking about deletion mutations, and specific like ATRX. Are there any targeted therapies that have been effective either in children or adults that have been developed for deletion mutations?
So I think in certain types, yes. I think not all genetic mutations are equally easily targetable. It depends potentially what part of the gene is altered. It depends on what sort of the downstream implications of those genes are. So yes, I think the idea behind understanding a lot of the genetic alterations, the mutations, is to find specifically targeted therapies that impact those things.
Yeah, it was just a little confusing because if you have something that's missing, it just seems like that would be hard to target something that's not
Sure.
there.
Yeah, and some of it depends on how it impacts the proteins and things that gene encodes too.
Yeah, okay, thanks.
Okay. Any other questions? Are we done? Sure. Okay, go ahead. We have time.
Thank you. I was actually going to ask Dr. Applebaum, but since you mentioned it as well, I thought I'd ask, MICN amplification, you discussed it, and that affects 1 of 5 families in here. What is the discussion, or has there been newer discussion around using MICN amplification as a prognostic factor? And is there new data that suggests that they may fare better if they respond to treatment?
Sure. So I think of a little bit what you may be alluding to is I think there has been some published data to show that patients who have MICN amplified disease may respond more readily to induction therapy. And there's a paper published by Dr. Pinto that has shown some of this, and that although historically MICN amplification we associate with sort of making you in the high-risk category and more aggressive disease, that amongst patients with high-risk disease, it hasn't necessarily stratified within that cohort, and maybe predicts better response. I think there's a lot of work being done to understand the interplay between all of the various factors, and how does MICN amplification impact different groups? Does it matter, if you have MICN amplification and respond well, that may give you one sort of prognostic significance, but if you don't respond well and you have MICN amplification, that probably means something very different. And so I think while we know a lot about these factors individually, how they all come together is still something that's being worked on, and understanding the best way to combine all these factors.
Any other questions? Okay, we're done? Okay, thank you, Dr. Sokol. We're going to go ahead and, we're a little bit early, actually. We're going to go ahead and break for lunch next door. If your kids are in the kids' room, you can go ahead and bring them into lunch. And we'll be back here at 1:30. Thank you. Oh, and be careful with security. Make sure you have your name tags on, because security at the hotel will stop you. So.
I'll take it. Yeah, I'll take both of them.
Thank you.